for 1.5 years, but I was doing just diabetic foot research, so very well acquainted with some of the settings in the United States.
Yeah, Kentucky is not too far from us here. It's only about 3-hour drive.
Louisville. I see. Yeah, that's right.
Yeah.
Well, it's nice to have Professor Gamal again. Jamal Mostafa, United States, is going to continue on talking about this trauma subject, and it will be also an interactive session. And we look forward for this session. Thank you, Professor Jamal, for coming back again, and we look forward to see you more and more in the future. The floor is yours.
Thank you for having me. It's my honor and pleasure. So we'll start with this, and I made a couple of slides here. It's not going to be a big lecture, so we lecture people. There will be some lectures in the future. We have the multiple choice question format, we have the lecture format, and we have the interactive clinical scenario format. So we'll have an interactive clinical scenario format supplemented with just a couple of slides so we can have them to remind us what the subject is. And would like that to be interactive. I hope you can hear me well and we can talk about this. So let's say we have a 30-year-old female who's a pedestrian struck by a car, and she's coming to the emergency room. 30-year-old previously healthy female hit by a car and coming to the emergency room. When you see her in the emergency room, you find that she, her blood pressure is 90 systolic over 50. She is tachycardic. Her heart rate is 130 to 135, sinus rhythm. And she is awake, alert. You put the pulse ox in her, her oxygenation is 100%. She is in pain, and when you look at this lady, anyone who can tell me, in a hypotensive blunt trauma patient like this, pedestrian struck by a car, what would be your differential diagnosis of potential causes of her hypotension? Anyone? Anyone can help us?
Dr. Moomin?
Yes, hello, it's Moomin here.
Yeah.
I think the main...
Well, basically, Moomin, if I'm asking you, what do you think would come to your mind in the emergency room down there where you are in the hospital, seeing this lady, and she's hypotensive, struck by a car? In your mind, what could possibly be the cause of the injuries that would cause her hypotension, or the cause of her hypotension?
So blunt injuries to solid organs, liver, spleen, deceleration.
So we can all follow you. So yes. solid organ abdominal injuries, right?
Yeah, so we'd have to classify the shock into hemorrhagic versus neurogenic. I think these are the main two problems.
So what do you think the most common one would be?
Hemorrhagic.
Hemorrhagic. Okay, so let me ask you specifically, just to be precise. Hemorrhagic shock, fine, that should come in your head first thing. Can you tell me the potential places where blood will be and will be lost in this lady?
Intrathoracic.
Good. So chest, her chest. Okay, yeah. What else?
Intra-abdominal.
Excellent. Abdomen. Okay, what else?
Long bones.
I'm sorry, say abdomen what?
Long bones.
So chest, abdomen, long bones?
Yeah, like a femur, like a broken femur with a lot of...
Anywhere else?
As a cause of hemorrhagic shock, no, but intrapericardial.
No, hemorrhagic shock.
Yeah.
Chest, abdomen, bones, like femur and things.
Yeah, I mean, and then you've got externally, but that would be obvious. You'll know the diagnosis
sure.
immediately.
But just to make sure that I'm clear, the abdomen, you think it includes the pelvis, or?
Yeah, abdominal pelvis, definitely, yeah.
Okay, but these are two separate things, Mu'min, right? You know that, right?
Yes, yes.
I mean, the pelvis is, as we're going to see here, is totally different from the abdomen. I don't think we should mix that. Okay. So this is a really good start. Chest, abdomen, pelvis, long bones, right? So if I tell you that this lady, she doesn't have any blood coming out from anywhere that you can see, and she doesn't look like she has a femur or long bone fracture. So we are left with chest, abdomen, and pelvis, correct?
Mm-hmm.
Right, so how do you narrow this down and try and find out where the bleeding is in these compartments?
Depending on the setting, this is the mechanism of the trauma is quite severe, so it will necessitate like a CT chest, abdomen, pelvis.
No, we're not gonna jump into that yet. I mean,
for that we can get a simple fast scan. We can examine actually the abdomen, look for signs of peritonism.
Okay, so, okay, yeah, exactly. The main thing, and I'm sure in the OSCE and all this, they really want to do this, and the British system is the same. Here, it's really very important that we be systematic and stepwise fashion in our approach of any clinical case scenario. So the first thing you need to start with is the clinical exam, correct?
Yeah.
Right. What can you see on the clinical exam that would point you that the bleeding is in any of these three places? We have an agreement now, it's either chest, abdomen, or pelvis. What can you see that would point you into one direction or the other? Clinically, on a clinical exam.
So abdominal examination, looking for signs of peritonism.
Okay, why don't we start with the chest?
Chest, I'm not sure if you might find evidence of hypoxemia if there's massive hemothorax.
No, not really. You listen to the chest. If you have a hemothorax, what do you expect to find?
Poorer entry on the side.
Correct. Decreased breath sounds. When you listen to that, you'll find decreased breath sounds. On the abdomen, you can look for abdominal distension and tenderness. How about the pelvis? The pelvis. What can you see? What can you see on examination of the pelvis, which is really important? Clinical examination of the pelvis that would point you that there is a pelvic injury leading to hypotension.
So pelvic instability on examination, pelvic tenderness.
What do you mean by pelvic instability? What do you mean by that? Can you explain that to us?
So clinically, the pelvis is when you apply pressure to it, it's not holding. It's unstable. There's obvious crepitus when you put pressure on the pelvis.
How do you apply pressure on the pelvis clinically? How do you examine it? How do you test for pelvic instability? You're absolutely right.
Bilateral hand pressure on the axis, spines, with some weight from your body. This is how I learned to do it, at least.
Okay, so right, so anteroposterior pressure on the anterior superior iliac spine, or sideways pressure on the hip region, right? And that will give you some indication of instability without being very aggressive. Right?
Also, examining the urethra and the anal canal for any obvious hemorrhage evidence.
Okay, so she's a female, so you're absolutely right. You may not really see that much, but if it was a male, what can you see on the outside that would indicate a bad problem in the pelvis?
Scrotal hematoma.
Thank you. Scrotal ecchymosis. You're absolutely right. And bruising. So this is excellent. This is really good.
I will give a chance to other people then.
This is excellent. So the decreased breath sound in the chest, it may indicate hemothorax. Abdominal distension and tenderness may be bleeding in the abdomen. And in the pelvis, pelvic instability, bruising on the lower abdomen over the pelvis, scrotal ecchymosis or bruising also is an indication. And of course, blood at the meatus is also important. Right. You've done with the clinical exam. What else can you use right there to help you define where the blood might be in the workup?
Sonography, fast. And
you really like technology here, you know.
Well, if we go simply, we can get chest X-ray and pelvic X-ray.
It's not if, it's critical, it's important.
Yeah.
It's not if, you have to do it. You have to do it. This is the ATLS protocol. It's mandatory, okay?
Yes,
so
yes.
What's in the ATLS, you have to be methodical. What's in the ATLS protocol that you should do next to look for places that could have blood in the ATLS?
So you do your primary survey radiography.
And what is that? What's the primary survey radiology? What is it?
C-spine, you wouldn't be looking for bloods, but that's one of the primary survey ones. And then chest X-ray and pelvis, pelvic
Okay.
X-ray.
I'm glad you're bringing this up. Just C-spine plain film is no longer ATLS protocol.
Yeah.
Plain cervical spine fell out. We took it out of the protocol of ATLS primary X-rays. We took it out about 10 years ago. It's no longer there because it doesn't really help you much. It's not accurate. So, and it's a waste of your time. We do have 2 X-rays that are essential in a primary protocol of this kind of a clinical situation. Hypotensive patient with blunt trauma. Let me repeat, guys. In a primary radiology survey of hypotensive trauma patient in the ER, it's mandatory to get 2 X-rays, 2 plain films. If you don't do that, it's a problem. You're violating the protocol. Plain chest X-ray and plain pelvic X-ray. Plain chest X-ray will give you pneumothorax, hemothorax. You may need a chest tube to fix that. Plain pelvic X-ray, it will give you right there a reason to believe that the hypotension is caused by major pelvic fracture. Now, this is used in the context of hypotension. For normotensive patient, hemodynamically stable patient who can walk and the pelvic exam is negative, you don't need a pelvic X-ray. But in a hypotensive trauma patient, you need a pelvic X-ray because the pelvic X-ray is really good at giving you an answer that the pelvis could be the source of hemorrhage. It's the plain film initially is not as good to tell you whether there is a small, tiny little fracture, pubic ramus, little scratch in the acetabulum or the hip. No, it's not really good at that. CAT scan is better. But the plain film initially is the reason the plain film initially is essential. It's in this scenario of blunt trauma and hemodynamic instability. Because you need to know right there, do I have a major pelvic fracture that's causing the hypotension? That's the main thing. So to reinforce that, we'll see here that there's a word here missed, it's high energy injury. This is a high energy injury. Usually it's caused by a motor vehicle collision, MVC, you may call it differently in Sudan, that's fine. Motor vehicle crash also is the word. Fall from a height, you see, it's a really bad thing. Pedestrian versus car. If you notice, guys, in all of these, the common factor in all of these is high energy. I really want you guys to remember that. All those listening to this today, please, if there is one thing you can take home message from this, the major pelvic fracture means that the patient sustained very high energy to break that pelvis that much. the pelvis, get a skeleton. When in the medical school, get one of the real skeletons. Look at get the pelvis. And I'll tell you something. Get a hammer and try to break this pelvis. It's going to take you a lot of effort. So to break this pelvis, it means that there is a very high energy impact to the body to cause this. Why are we stressing this fact? We're stressing this fact because of the importance of associated injury with pelvic fracture. Please, guys, in your practice, in your training, whenever you see a pelvic fracture, today we're not talking about fixing bones. Today we're not talking about fixing bones, guys. By the way, I'm a general trauma surgeon. I'm not an orthopedic surgeon. We're not going to talk about any of that. We're talking about, trauma aspect. Whenever you see a pelvic fracture, think about associated injuries. And those associated injuries are not minimal. They are a cause of mortality. So here is the point. What we should worry about when we see a major pelvic fracture? The major hemorrhage and associated injuries. These are the two things that should concern us whenever we see this kind of a bad pelvic fracture. The association with hemorrhage, shock, hemorrhagic shock, and the association with other injuries. So back to you, Mu'min. Are you with me still?
Yeah, I'm with you.
Associated injuries, can you give me an example? What kind of associated injuries should worry about in this lady? Now, your lady, by the way, just to move on with the scenario, we said we're going to remain interactive. You get a chest x-ray. I'm giving you an update about your patient. You get a chest x-ray, it is normal. Totally normal. Good lung sounds and good air lung entry, no hemothorax, no pneumothorax. Abdominal exam, minimally tender, but no distension. You do get a plain film of the pelvis in your patient, and what you see is a major pelvic fracture, like open book, separation of the symphysis pubis, and also fracture of the sacroiliac joint. Okay? I want to ask you now, what would come into your mind about associated injuries in this lady here?
So deceleration injuries like aortic injuries, intrapericardial bleeding.
Excellent. Traumatic aortic disruption, right?
Yeah.
Excellent. What else? Just be specific here. Traumatic aortic disruption. What else?
And then
so guys, so for those who are joining us or are joined us already, we are talking about specific associated injuries, typically and high potentially associated with major pelvic fracture. I want to remind everyone who's listening, guys, today we're not talking about simple pubic rami, hairline fracture in an 80-year-old lady who fell, out of bed or down. No. We're talking about major pelvic fracture, right? So aortic injury, what else?
So neurogenic shock due to spinal cord injuries, vertebral fractures.
No, yeah, maybe. Okay, what else? Yeah. Of course, falling from a height is a spine injury. What else?
Associated head injuries. Absolutely.
Traumatic brain injury.
Yeah, traumatic brain injury.
Traumatic brain injury, TBI. TBI, that's not my abbreviation, guys. That's the normal, that's the standard book of abbreviation, traumatic brain injury. Right, what else? Again, guys, anybody can jump in now. When we get a little bit of pause, we can jump in. What other injuries?
Hi, Professor.
Sorry, hey, how are you? What do you think? What other injuries?
In generally speaking, pelvic bones and pelvic region contains the major organs here. It contains blood vessels like aorta and its purification. Secondly, nerves could be damaged. Then bladder, because
Oh,
it's
just a second. Let me. So you're talking about genitourinary injuries, right? Right?
yes,
Bladder. Okay. What else? What else could be injured?
the distal bowel injuries.
What do you mean by the distal? What's the most distal part of the bowel?
Yeah, rectum, lower distal sigmoid and upper rectum.
Rectum. That's right. Rectum. Right? Okay. This is really good. What other injuries might be there with pelvic fracture?
Major vessels.
They are not in the pelvis, but remember, high energy injury. So what can you get?
Yeah, major vessels that contain in the posterior abdominal wall.
No, how about liver and spleen? What's wrong with that?
Yeah, solid organ injuries proximally.
Yeah, solid organ injuries, right. One more left, and it's very important, and you shouldn't miss it. We shouldn't miss. We talked about it actually last time in the penetrating trauma, and we said you should never miss this injury.
Kidney injuries.
No, not really.
Injuries.
Sorry?
Duodenal injury.
Urethral injury.
No, that's genitourinary. What did we talk about last time that and we said you should never? Diaphragmatic injury. Absolutely. Diaphragmatic injury. Can you imagine, guys? Diaphragmatic injury. Can you imagine because of the impact, how major the impact, somebody who fell from a height. Look at this. Fall from a height, 3 or 4 or 5 stories. He can have all these injuries. The most important out of these actually, guys, is the aortic arch disruption and the diaphragmatic injuries.
Can I add something?
Sorry?
One in the mechanism, I think when you are falling from a height and then you create a high pressure interabdomen because you close your glottis and your sphincters when you land. So a high compression will result in this capsular injury, rupture of the capsules and the diaphragm, splenic capsule, liver capsule. So a high pressure in the abdomen compressed.
100%, absolutely correct, 100%, thank you. So here we go, guys. Head injury, abdominal injuries, aortic injuries, rectal injuries, genitourinary injuries. It's a bad problem, guys. Do not take this lightly. Do not take this kind of injury lightly. If you get that on your night call of trauma, whatever, this can consume the entire night of work from you. And you know something? It'll consume the entire night from you as a general trauma surgeon. And the orthopedic part is maybe very minimal, if any, as we'll see. Tonight is going to be very minimal. The orthopedic guys can fix that in the future. That's fine. But what's going to kill the patient tonight is one of these that we as general trauma doctors have to deal with. Because that's why I told Muhammad that when he heard that pelvic fracture, he said, you know, it's going to be orthopedics. I said, no, it's not going to be orthopedics. So it's far from that. So the hemorrhage, we have to remember, the hemorrhage is mostly venous, guys. 90% of the time, it's mostly venous. And 10% it's arterial. But going back to you, Momin, you here with me again? Can you put yourself on?
Yes, yes.
Okay. So, Momin, why is it a problem? Why is hemorrhage is a major problem when it happens with pelvic fracture? Why do you think this is?
It's difficult to control, main problem.
I think you're very close to the point. The pelvis can take up to 1.5 liter, just the pelvis as it is.
Yeah.
Just as it is, can take up to 1.5 liter. This pelvis takes a child, you know, in pregnancy, 9 months. So it can take up to 1.5 liter of blood. Add to that, if it's an open book with bigger capacity of the pelvis, and I'm gonna make it worse, the hemorrhage can spread up in the retroperitoneum, which is unlimited.
Yeah.
And he said it's difficult to control, which is absolutely right. You know what I may add to this word, difficult to control?
Mm-hmm.
You cannot tamponade it.
Yeah,
There's
you can't
no-
compress. There's
There's
no.
no tamponade effect.
Yeah.
It
Yeah.
keeps going. So you can imagine the patient can exsanguinate. That's the problem. That's why hemorrhage in this kind of fracture is a problem, right? So hemorrhage pelvic fracture is essentially bleeding. Look at this. That's exactly what I said. It's the slide just says the same, right? Okay. Causes bleeding into the retroperitoneal space. When intact, the retroperitoneal space can accumulate up to 5 liters, the entire blood volume. Okay, you can imagine the patient can lose the entire blood volume with the blood going up in the retroperitoneum if we don't do anything about it. See? So, is it serious, this problem? Of course it is. The mortality is up to 6 to 10%, actually more than that. And guess what? The mortality of the pelvic itself, it's almost half and half. Half and half. Half is related to the pelvic fracture, and the other half from other associated injuries, mostly head injury, that can cause the death. Right. So the plain film is part of the radiograph for blunt trauma, routine radiograph. So let me ask you before we go any further, Momin.
Mm-hmm. Mm-hmm.
Which trauma patient you do not need plain pelvic X-ray on? You can say, fine, I don't need it.
Which one you don't need it in?
Correct. Which ones?
Open fractures, or
not this patient,
mm-hmm.
but in general. Which basically what I'm asking you, which patient you would not worry about major pelvic fracture right this second? I don't think it's the case, so I don't need a plain film. Which one?
Injuries that are not high injury, not high.
Okay, that's a
energy.
good point. That's a good point. Low energy mechanism, I agree. What else?
Ambulating patients.
Excellent. The patient can walk and all this, absolutely. What else?
No discernible tenderness, pelvic tenderness.
Negative clinical exam.
Yeah.
Yes, good, excellent. What else? One more important thing, very important, which this lady has. That's why she got a plain film. What's she present with?
Shock. So no
Thank
hemorrhage.
you.
Yeah.
Thank you. Thank you. So hemodynamic, here's the talk, guys. Here's the point. The question is, when can I omit, not do plain pelvic X-ray in a trauma patient, blunt trauma patient? Hemodynamically stable patient, negative clinical exam, no tenderness, ambulating. If I have all the, and low energy mechanism, if I have all these, you know something, I can omit the plain pelvic X-ray. And I tell you why. Because the patient may have, yes, maybe small pubic rami, hairline fracture, undisplaced, fine. But you know something? He's hemodynamically stable, he's doing fine. I'm gonna get a CAT scan, and the CAT scan will show me much better than the plain film. But I don't really need to know about the pubic ramus fracture because it's not the cause of my problem right now. So I don't really need to know that. So it's really important that we have this in perspective, guys. So plain film, many studies indicate that the patient with negative clinical exam, here you go, Moment. Negative clinical exam for pelvic injury, the pelvic film is unnecessary. You agree?
Mm-hmm.
Right, so we agree that that's not indicated. Okay. CT scan with reconstruction in the dimension, the reconstruction like we talked about last week, really identifies all pelvic fractures. And not just this, it gives you an indication about any associated abdominal injuries. Now, leave that CT scan. The problem with CAT scan though is one thing. You have to be hemodynamically stable to be able to go to the CAT scanner. We do not take hypotensive patients to the CAT scan. Right, so going back to the patient now, before we go any further, Moment. You do the plain film of the pelvis and you do find very bad pelvic fracture, okay? Can you tell us where you're gonna go from here? Chest is fine. Pelvic plain film shows bad fracture and she's hypotensive. No long bone fracture and no other source of hemorrhage that you can see. What would be your next step, Moment?
So am I right in assuming we've applied the pelvic binder for this lady?
No, you tell me. Do you want to do that?
So we need to apply the principle of damage control resuscitation for her. So we need to apply pelvic binder.
Absolutely, guys. Anybody who's listening to us, this is an excellent point. Pelvic binder. Guys, to the extent, if we do not mention pelvic binder in our oral exam here in the United States, in these clinical scenarios, our oral exams here are pretty tough. They're really tough, very stressful event, very stressful for trainees. And if you do not mention pelvic binder in this clinical scenario, which is hypotensive trauma patient with major pelvic fracture, if you do not mention pelvic binder, this is a very major negative point in your score. You may not even pass this case in the exam. Good Moment. Now, pelvic fracture, pelvic binder is on. What's your next step?
So activate major hemorrhage protocol.
By the way, guys, the rationale for pelvic binder, the philosophy for pelvic binder, remember what we talked about? The pelvis takes 1.5 liter of blood, and Moment told us that he cannot tamponade this, and if the pelvic is open fracture, it's even bigger. It'll take 2 or 3 liters of blood. What you're trying to do is to minimize that volume, to tamponade the bleeding. That's what you're trying to do with the pelvic binder. So you tamponade the bleeding. Good. So Moment, your binder is on. What you doing next?
Yeah, so major hemorrhage protocol, prepare blood and blood products.
Good. Massive blood transfusion protocol, fine, excellent. What else?
Like I said, follow principles of damage control resuscitation and maintain systolic at around 90.
Okay, what's next? Okay, good. All this is good. What's next?
Yeah. Next is to finish the primary survey in the OR, I think, packing if she continues to bleed.
Okay. I just want to remind you, the only thing you got so far is plain chest X-ray and plain pelvic X-ray.
Okay,
are you done? Are you ready to go move somewhere else?
No, so after applying pelvic binder, if the patient stabilizes, it might be a good time to go for a CT scan.
No, the patient didn't stabilize.
Didn't stabilize.
Moment, let me give you a clue. You ruled out the chest as a cause of bleeding, right?
Mm-hmm.
And you have the pelvic, possibly the cause of bleeding, right?
Mhm.
Could bleeding be anywhere else? And there are no long bones. Could bleeding be anywhere else we don't know about?
So we need the
We haven't checked yet.
We need to check for the associated injuries we talked about. So we need to check the pericardium.
Pericardium is negative. How are you going to check the pericardium? Sorry. How are you
No.
going to check it?
Fast scan, e-fast or fast scan.
Okay.
Focus assessment, yeah.
And fast is important for the pericardium. Is it more important somewhere else?
Intra-abdominally Morrison's pouch.
Absolutely. Absolutely, Moment. The bleeding could be in the abdomen. She could have grade 5 splenic injury. She could have grade 5 liver injury. Right? We don't know that. So what's your next move? Fast of the abdomen, correct?
Yeah.
Right?
Mm-hmm.
And you know something? What if fast is grossly positive? You have blood in both gutters. Can you tell me what would be your next step?
Next step will have to be exploration, damage control surgery.
Laparotomy, correct?
Yeah.
You with me?
Yes, yes.
Yes. Guys, you know something? At the end of this talk, let me tell you how I tell our residents and trainees here. These patients, major pelvic fracture, more than any other trauma patient. You know what I tell the trainees here? These patients are like you driving a fast car, 90 miles or 100 kilometers an hour on the highway, and you have different exits that would take you to different places. If you take the wrong exit with this patient, the patient is going to die. So the most important thing is from this emergency room trauma area, you have to make sure the exit, the place where you're going to from here is the right place. And let me tell you one thing. These exits, the right place, the places, the potential places that you're gonna go to from here, I can tell you where they are. So we can all get together. One is gonna be the operating room, potentially. The other potential is gonna be angiography. The third potential is gonna be CAT scan, and then either angiography or ICU, intensive care unit. And everybody, at the end of the day, after all this is done, is gonna go to intensive care unit. So let me repeat, guys. This lady for Mu'min in the emergency room, after applying the binder and the chest x-ray is negative, and she's receiving the blood, she's hypotensive. In my mind, I'm thinking from here in the trauma area, the potential places I may go to is the operating room, the radiology suite for angiography, or the CAT scan and then ICU. And the first two, when I'm done, also gonna go to ICU. Where I'm gonna go with the patient, it depends what happens and it depends what I find. And that's what Momin is gonna tell us now. Right, you're gonna do a fast exam. If the fast is positive, which exit you're gonna go to?
Fast positive patient hypotensive will go for exploration.
Laparotomy in the operating room, correct?
Yes.
Right, and you're gonna have the abdominal binder on. Before you go to the operating room, even if the fast is positive, are you gonna do a couple of things in the trauma bay with this patient before you actually move? A couple of things to check on, very important. And let me give you a clue what I mean by that. Couple of things that you have to do to exclude other injuries we talked about earlier, and I have them written in front of me right here. And the simple ways to exclude them, what are these?
I'm not sure what you mean. We've already done the fast scan. We've already done the X-rays.
What else can be injured in the pelvis, Mom?
Rectal injuries.
Okay, right.
So
How are you gonna potentially see if this is the case? What you gonna do? In the ER.
Examine the groin. Do a PR.
Rectal exam.
Yeah.
Right. Rectal exam. See if there's any blood, or you can feel any bone. You could even feel bone sticking out, injuring the rectum. Right. Yeah. Rectal exam. What else?
Bladder injury.
How do you know that? How do you
catheterization?
Sorry?
Catheterization. Catheterization. To put catheter.
Before you catheterize this lady, what you gonna do?
High rising.
Examining the external genitalia first.
Okay, especially in a man. In a woman, it's not that important because the urethra is short. It doesn't get injured. But in a man, you're gonna look at blood at the meatus, scrotal ecchymosis, rectal exam. You're gonna feel the prostate, make sure it's not high riding prostate. These three, if you find any of them, blood at the meatus, massive scrotal ecchymosis, or you cannot feel the prostate, suspect urethral injury, not bladder, urethral injury. So what you're gonna do before you put the catheter?
We could inject urethrogram.
Absolutely. Absolutely. You're gonna get the Foley catheter. Don't put it all the way in. Put it just small, about less than an inch, about 2 centimeters in the penis, almost not beyond the glans penis or so. Inject contrast. If you find urethral injury, do not put the catheter in. Do not advance the catheter if you find urethral injury. Instead, this patient is going to the operating room, is going to need a suprapubic catheter, right? Now, if you do not find urethral injury, you inject the contrast, the Foley is a small length in, it goes into the bladder nice, there's no rectal contrast, you're going to advance it in the bladder, right? Yeah. You don't get hematuria, fine. You excluded urethral injury, you excluded bladder injury. As long as no blood at the meatus, no, to recap, to exclude urinary tract injury associated with pelvic fracture, here are the things that will help you confirm no urinary injury. Urethra or bladder. Negative exam, no blood at the meatus. No big scrotal hematoma. Normal prostate exam. If you suspected anything, do a urethrogram. If it's negative, that's good. Then put the Foley catheter. If you get clear urine, you don't need a cystogram. If you get clear yellow urine, that rules out bladder injury. You're done, good. If you get hematuria, while the Foley catheter is there, inject contrast, and that will give you an idea whether there is a bladder injury or not. If there is a bladder injury, you're going to leave the Foley in, and we can talk about how you're going to manage that later. Okay, so before we move, even with the fast, positive, we go into the operating room. But before we do that, we need to check urinary injury and rectal injury. And in a female like this, one more pelvic injury. What would that be? Female. What would that be?
Uterine injury.
Sorry? Female. I'm giving you a clue. What would that be?
Uterine injury.
Associated.
Vaginal injury. Vaginal injury. you're gonna do a vaginal exam to make sure there is no blood and no bone sticking into the vagina. So rectal exam, vaginal exam in females, blood at the meatus, scrotal edema, hematoma, urethrogram if you need it, cystogram if you need it. Now you covered genitourinary injuries in the emergency room. In the emergency room, you still haven't gone anywhere. You're fast positive, you're absolutely right, Moment. We're going to the operating room to take out a spleen or fix a liver or anything like this. So, no, your fast is negative, Moment. Now what?
Fast is negative, then potentially angiography to see if there's any active arterial bleeding.
Okay, so fast is negative, you're gonna go for angiography, right?
Yes.
I agree, you're absolutely right. Angiography and you're gonna go from here. So I hope you can see the screen, guys, because it's really, if there's a couple of things you need to take from that, you can print this one and take it because it's really very nice algorithm. Let me tell you guys, we're gonna go over that and then so we can wrap it all up. Let me tell you guys, this case here, a lot of our trainees, first of all, a lot of trauma patients here are dying because of mismanagement of this kind of injury. Mismanagement. And also, a lot of our trainees fail this question in the American Board of Surgery oral exam. And they find it very hard to finish this scenario. So let's go over this, guys, this algorithm. And by the way, guys, always try for your oral exam, but even for your real life, for your practice, always try to have everything as an algorithm, you know? Have everything as an algorithm in your head, you know, what should I do next? If this is this, I'm gonna do that. If this is this, I'm gonna do that. So always try and keep that. Make everything like pathway, algorithm, so you would have a plan of how you manage things. Let's see what you can see here. And I hope you guys all can see this, everybody?
Yes.
Okay, we'll go over it together so we can share any questions or concerns. You have pelvic fracture, hemodynamically unstable. If the answer is no, perfect, that's a good day. Guess what, you're gonna go? CAT scan. And Moment, did you see, forget the details, we're gonna go over the details. Look at this. Do you see the boxes at the end of everything where people are going? Do you see the exits? SICU, Surgical Intensive Care Unit. SICU, look at the bottom. Look at the bottom of the page. SICU, Surgical Intensive Care Unit. SICU, Surgical Intensive Care Unit. SICU, Surgical Intensive Care Unit. Do you see that? Everybody eventually, after taking the right exit, will go to one place because it's a sick patient. We need to Surgical Intensive Care Unit. SICU. Look at the places in the middle. Look at this. Look at this here. CT scan, angiography, laparotomy, angiography. See the exits where we're gonna go. So, okay, let's see. Let's go over this and see what we said is right or wrong. If you are hemodynamically stable, you go into CAT scan. If you see, stay on the CAT scan first. If you see a blush, see the angiography, and you see extravasation of contrast, the patient is stable. If you see that, you're gonna go to angiography for embolization, okay? If you don't see that, you're gonna go for pelvic fixation. Do you see where pelvic fixation is, guys? Do you see where orthopedic work is? Way down there in the algorithm. And we're not concerned about their stuff right now. Okay, let's go back first. However, if you're hemodynamically unstable, that's your patient today, moment. That's your 30-year-old lady. Let's see how we're gonna do that. Alert the orthopedic team on call. Hey guys, hello, we have a bad pelvis here. I just wanted to let you know. Okay. Activate the blood bank massive transfusion, like Mu'min said. Immediately transfuse 2 units of blood, don't wait. Excellent. Alert the operating room and anesthesia on call. Tell them, guys, we have a problem. We may be coming up to see you soon. Alert angiography suite and intervention radiology. Sheet pelvis or place pelvic binder. Do you see that moment? That's why we said that it's critical, and people would fail, will not, if they don't say that on the oral exam or the OSCE. Chest x-ray, thoracic ultrasound, true loud thoracic injury. And we did exactly this. We ruled out hemothorax and pneumothorax. Let's see where the arrow is after that. Fast or diagnostic peritoneal lavage or diagnostic peritoneal aspiration, DPA. Honestly, guys, right now, this day and age in the United States, and you guys can tell me how you're doing in Sudan and other places. I really want to know. I'd love to know. In the United States, there is no such a thing as DPL anymore. There is no diagnostic peritoneal lavage anymore. Almost all our trainees don't do any diagnostic peritoneal lavage. We replace this with DPA, diagnostic peritoneal aspiration, or some people call it DPT, diagnostic peritoneal tap. Here's the point. We said we have the FAST exam now. This can tell us about major bleeding 90% of the time, whatever. At times, if don't trust the FAST, I think the FAST is false negative. How can I make sure that there is major bleeding in the abdomen? And remember, guys, what we're looking for here is a major bleeding, not tiny, small amount of bleeding. No, no, no. I am looking for a major bleeding in the abdomen in order for me to do a laparotomy. I don't care if there is a grade 1 splenic injury that's not causing the hypotension. I'm not going to do a laparotomy on this. I'm going to go to angiography instead. What I want to know is a major abdominal hemorrhage that deserves a laparotomy. And how can I prove this? DPA, diagnostic peritoneal aspiration. Aspiration. Make your cut like you normally do for DPL, supraumbilical in this case, supraumbilical in pelvic fracture, because you don't want to enter the pelvic hematoma, and get a 10 cc syringe and put it in the abdomen and aspirate. If you get gross blood, yes, your answer is here. Go and do laparotomy. If you don't get a gush of blood and the aspiration is negative, don't go to the operating room. Your answer is not in the spleen or the liver. Your answer is in the pelvis. Go to angiography. So look at this here. FAST or DPA, it should be DPA actually. Significant hemoperitoneum. Do you see that word, guys? You see the word? Look at the word. The word has a lot of meaning. The diagram doesn't say hemoperitoneum. It qualifies this. It says significant hemoperitoneum. And that's exactly the point. We're not going to the operating room with a tiny little DPL, put the whole bag in, put it to the floor, find the pink fluid. No, that's not the DPL, the injury that needs a laparotomy. I know the spleen is injured. It's probably a grade 1. Who cares? I'm not taking the spleen out for that. It's the pelvis that's the problem. And I need to be in the right exit, right place, which is angiography in this case. However, I want to know if there's a significant hemoperineum. Look at the word. Significant hemoperineum, yes, go down. Go to the operating room, get your orthopedic guy with you, do your laparotomy, open the abdomen, take the spleen out, pack the liver, fix the liver, whatever needs to happen, right? Solid organ injury. Your orthopedic guy is pinning the pelvis, putting an X-fix to even getting rid of your binder and putting something more neat for tamponade. This is not definitive. This is still tamponading, but the patient is under anesthesia, so take advantage of that. And if you want, while you're there, do a pre-peritoneal packing to control the hemorrhage even more. When you're done with all this, spleen is gone, there's no bleeding in the abdomen, your orthopedic guy put the X-fix on, guess where you're gonna go after that? Angiography. You took care of the abdomen, go to angiography, see if you can embolize something to stop the bleeding, and look at the last box, SICU, surgical intensive care unit. Okay, let's see if I do not have significant hemoperineum. What if I don't have significant hemoperineum? Look at the arrow. No. If there is no hemodynamic, if there is no massive hemoperineum, if you're still hemodynamically unstable, look at the arrow. Yes, go immediately to angiography. Again, your hemoperineum, no significant hemoperineum, and you are hemodynamically unstable, your exit here is radiology suite for angiography. However, if you stabilize with the blood, you're looking better. Moment activated the blood protocol. She had 3 units of blood. She doesn't have blood in the abdomen significant, and she improved with the hemodynamics. You know what? Go to CAT scan. She's stable now. She responded. Go to the CAT scan and follow the right side of the screen on the CAT scan. However, if you're hemodynamically unstable still, go to angiography. Angiography, go to angiography, and if angiography is not available, unfortunately, put the X-fix and do the pre-peritoneal packing if you don't have any facility to do the angiography for you. Hopefully by that time you stabilize her enough, or the angiography became available even in another institution. She has to have angiography and then go to surgical ICU. If your angiography is available and good, follow the arrow to the right side of the screen, angiography, fix the fracture, you become stable, you put the X-fix on, or orthopedics will fix the fracture and go to surgical ICU. So you see, guys, how important the algorithm is and what you do with every single step in these people. And I think it's really important. All right, guys, any questions?
You get an expanding splenic hematoma that probably needs to be followed the patient with an expanding hematoma. I mean, they call it later a late rupture of the spleen. And the other thing is an expanding retroperitoneal hematoma when doing a laparotomy.
Right. You absolutely can get that for sure, yes. Any other questions, guys? Any comments? Okay. Make sure, guys, you keep the algorithm here, and next time we'll talk about something else related to that, but a little bit different. But make sure you keep the algorithm, please. It's really, really good algorithm. When I found that, I printed it and I gave it to our guys here because it's really important case on their oral board, and of course important clinically when you're doing trauma. Okay. All right. Thank you, guys, and hopefully we'll see you next time, okay?
If anyone have any comment, please can comment or ask directly.
Any questions or comments, guys?
Welcome, Dr. Rehab. Welcome, Dr. Rehab. Please unmute yourself and ask your question. I think she had internet connection problem. Welcome all of our Sudanese surgeons, senior consultant, Professor Sulaiman Hussein, Mr. Sam Dirdiri, Mr. Ayman Nasr, and all of the international participants are welcome.
Yes, one question, Mohammed.
Welcome, Professor.
What about an expanding splenic hematoma? Usually they call it rupture, especially in blunt trauma, get a subsplenic hematoma. You need to follow these patients and you might need to interfere sometime. And the other thing, if you do a laparotomy to find an expanding retroperitoneal hematoma without having previous probably good assessment of CT to know where it is, shall you open it or leave it?
These are excellent points, Dr. Rashid. These are excellent points. Thank you for bringing these up. For the splenic subcapsular hematoma, I don't think I wouldn't really, you mean when I'm, while you're doing a laparotomy, right?
Yeah.
I wouldn't really interfere with it. I would leave it alone. I think that the majority of those can settle by themselves. And if you have a blunt retroperitoneal hematoma that's expanding, this is, so it depends really on any expanding retroperitoneal hematoma, even with a blunt trauma, it should be explored. If it is expanding, especially retroperitoneum, if you're up there in the abdomen with the laparotomy, you have two zones, as we all know. We have zone 1 and zone 2. There are 3 zones, as we know, guys, for the retroperitoneum hematomas, 3 zones. Zone 1 is the aorta and IVC and their branches, major vascular injuries. Zone 2 is the perinephric. Zone 3 is the pelvic, which we have the injury in. As Professor Al-Rashid is asking, very important point, very important. If you are in the abdomen and you have a retroperitoneum in zone 2 or 1 that's expanding, you have to explore. Because remember, guys, and thanks, Professor Rashid, for bringing this up. I think it's important. But remember, the mechanism is a high energy mechanism. And you are in the abdomen and you have expanding hematoma in zone 1 and zone 2, you have to explore it, because you could have kidney injury that needs to be addressed, could even reach a nephrectomy, that's fine. You have a major problem. Or IVC or aortic injury. The mechanism is a high energy. Nobody said falling from a height 3 stories or 3 floors or 4 floors is not going to injure your aorta or IVC. So if the hematoma is expanding, it has to be explored. Now, if the blunt trauma and the hematoma is in zone 2, perinephric, either side, and it's not expanding, we're not going to explore. But if there's a hematoma in zone 1, regardless, whether expanding or not, regardless, penetrating or blunt, it has to be explored.
So you have to have a backup here. I think you need to, before you explore it, you might need some probably a vascular surgeon or a...
100%.
That's
Absolutely.
right. And back to my previous question about subcapsular. You have a patient with a blunt trauma, is stable, you do the ultrasound showing a small subcapsular hematoma of the spleen. The question here would be, you can't keep the patient in hospital, but there is a possibility that this is going to expand and he might come in 2 or 3 weeks. So what is your probably plan of follow up these patients with probably ultrasound or?
Excellent question. Thank you. So this is a patient that we have an ultrasound. He's hemodynamically stable, spleen injury, subcapsular hematoma, and he's doing fine. Usually what we do with these people is we admit them, observe them overnight, get repeat hemoglobin maybe every 6 hours just till next day. We usually let them walk around. We may not allow them to eat just overnight. Next morning, if the hemoglobin is stable and the patient also is hemodynamically stable, we actually send them home without any further imaging at all. Nothing. We just let them go. We used to be much more aggressive about re-imaging and restriction of movements. We used to keep them in bed, stay in bed for 2 or 3 days, go home, stay in bed for a week, and all this. We used to repeat the CAT scan and all this. Nowadays, splenic injury that's observed, subcapsular hematoma, hemodynamically stable, no requirement for blood transfusion for 24 hours, usually we send them home without any further follow-up. We see them in the clinic, of course, but we don't do anything. We just see them in the clinic after that, a week or so after that, and that's about it. So.
Thank you.
Welcome, Mr. Ayman Nasr. He's trauma surgeon working in Saudi Arabia. You're welcome.
Welcome.
Assalamu alaikum.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Professor Gamal, Hayat Allah, thank you very much. That's very informative, and I really enjoyed the discussion. I have just something that I would like to get your opinion about.
Sure.
As we all know that pelvic trauma and pelvic injury, the first line of management normally is a non-operative, and if there is evidence of extravasation, we go for interventional radiology and embolization.
Sure.
This facility is not commonly available in Sudan. Would you like to, would you like to enlighten us a little bit about the operative role of pelvic bleeding and retroperitoneal packing for pelvic injuries?
Right. Yeah, I'm glad you're actually mentioning this because it's a new thing, relatively new even here. And the reason it's relatively new that we're resorting to pre-peritoneal packing is, for the most part, angiography here is available, but sometimes it's not. Sometimes you work in a trauma facility that's far from a tertiary center that has angiographic ability. So in this instance, to answer your question, your approach is going to be depending on two things, on one thing actually. Whether you're in the abdomen already or not. So, no angiography, you're hemodynamically unstable, Munir did the fast, or Mu'min did the fast, and it is positive, is in the abdomen, taking the spleen out. You know that you don't have angiographic facility. At this point, you're right there in the abdomen, it's easy. Do not violate the pelvic hematoma itself, if you can. If it's not violated, don't violate it. However, go retropubic, pre-peritoneal, leave the pelvic floor as it is. Usually it's bulging, hemorrhagic, looking bad. Don't poke in this, because if you poke in it, you lose the tamponade, which is helping you some. Instead, go to the cave of Retzius, if you would, the pre-peritoneal retropubic space, which you can easily be found. It is actually the same place where you place the mesh, pre-peritoneal mesh repair for inguinal hernia repair laparoscopic. It's exactly the same place, right? The same place that Stopa did the operation for inguinal hernia repair in the pre-peritoneal space, exactly the same space. Go on that, get your folded labs, lab pads, folded, shove them in that space really, really tight. That's your pre-peritoneal packing. Take the spleen out, and as Momin said, it's a damage control fashion. Get the vac sponge or the Abdera or the vac or even the towels or something, and the towel clips, as you can see it, and get out and either transfer the patient where angiography may be, which is ideal, should be the case actually, achieve some stability, and go, and ideally this patient should be transferred somewhere where there is angiography, because what you've done is not a permanent solution. It's a stabilizing solution for this, the pre-peritoneal packing. Now, on the other hand, if you're not in the abdomen, Momin did the FAST and it's negative, or did the DPA, diagnostic peritoneal aspiration, and it's clean. No fountain of blood. I don't need to do laparotomy. In this case, you don't have angiography. Again, I'm saying you don't have angiography. Ideally, it should be in angiography suite, but let's say you don't have this ability. Go to the operating room, take the orthopedic guys with you, and make a small suprapubic midline incision. Patient is under anesthesia, of course. Carefully dissecting there, avoid entering the peritoneal cavity. Please try not to enter, and this is a trick, that's why this is tricky. Try not to enter the peritoneal cavity, because if you enter the peritoneal cavity, you're going to lose your tamponade. And again, get the folded sponges, put them in the retropubic region, put them as tight and as much as you can to fill in the pelvis in the pre-peritoneal space. Have your orthopedic guy pin the pelvic and put the X-fix, tighten it to achieve more tamponade. And again, ideally, the patient should go to angiography after that, and it may be in a different facility to get angiographic embolization. It's going to come back to you, can take the packs out, and the orthopedic guys can do definitive repair when the patient is more hemodynamically stable. So I hope that answered the questions.
Yeah, thank you very much.
Thank you.
Dr. Ismail Ibrahim, you are welcome.
Assalamu alaikum, Prof. Thanks for having me. My question is regarding the use of Reboa that can be potentially used to control bleeding as an adjunct to getting your patient resuscitated properly and ready for theater.
Absolutely, it's no question. If it's available and you waiting to go in a definitive place, not in the abdomen, not in the abdomen. And again, it's an adjunct for you if you are waiting to go to angiography. If you're transferring the patient somewhere where angiography is available, almost like a pre-peritoneal packing, absolutely. Make sure when you inflate the Reboa, which is not available everywhere, you guys can tell me how available that is where you are, because even here is not really widely used, you know what I mean? Yes, you can inflate the Reboa till you transfer the patient somewhere to get angiography. But there is no use if you indicate. All these questions, guys, are related to somebody that you're trying to control the bleeding, temporize it till you do angiography, and you're not in the abdomen. Right. Good question.
And the second question, Prof, that I want you to ask, if we've established that only 10% of these pelvic bleeds are arterial, is angiography so important in this critical stage that we need to go through, especially if we now have a patient that has hemodynamically responded and we've decided to go in for laparotomy for other causes and pre-peritoneally pack the pelvis. Of what value is angiography, except for maybe diagnostical, in these types of patients?
Right. That's an excellent question, actually. And the answer, you know something, it's really important. And it probably should have been on the slide. Despite the fact that arterial hemorrhage represents only 10% of pelvic hemorrhage, it is the most common cause of continued hemorrhage in these patients. Why? Because venous hemorrhage, which is 90%, very likely is going to be controlled with the binder and the X-fix and the packing and all this. The one that's not going to be controlled and it's going to cause continued hemodynamic instability is the arterial bleed. And that's,
yes,
those are the ones who need angiography. You're right. You're absolutely right.
Okay. Okay, thanks, Prof.
Thank you. So in other words, guys, so let me put it this way. So if you get 100 patients, with major pelvic fracture who are hemorrhaging, hemodynamic instability and hemorrhage in the pelvis, 100. 90 of them will have venous bleed that can achieve stability with non-angiographic measures like binder, X-fix, blood transfusion, packing, whatever. However, 10 out of them, however, so 90% of them will have this. If they remain hemodynamically unstable, despite all this, the cause of this is likely the 10% arterial hemorrhage, and they do need angiography. Absolutely.
Sir, we have the last question from Dr. Muhammad Nasruddin. He asks, technically, how do we explore retroperitoneal zone 1 expanding hematoma?
Yeah, that's an excellent question, actually. As Professor Al-Rashid mentioned, actually, probably definitely before you embark on that, you do need probably a vascular surgeon also. But anyway, to expose that, it's the infracolic, infrarenal aorta, and to expose the infracolic, infrarenal aorta, you eviscerate the entire small bowel to the right side of the abdomen by the gallbladder. You reflect the mesocolon and the transverse colon up on the patient's chest. So on the patient's chest is gonna go the transverse colon. The small bowel is all gonna go in the right upper quadrant. Right there below the ligament of Treitz, you're gonna open the peritoneum, extend it. That's where you're gonna expose zone 1 for aortic injury. Zone 1 for aortic injury. Now, for caval injury, it's a different story. You're gonna do an extended right, extended right medial dissection, medial rotation, extended right medial rotation. You're gonna start with mobilization of the right colon, cochlearization of the duodenum, extended medial rotation of the entire thing. That will give you the whole infrahepatic aorta. Infrahepatic aorta, which is still zone 1. So
this is what is it what we call Kettelbrach, the procedure?
Correct. Absolutely. Medial visceral, right medial visceral rotation, extended, right.
One last question, Mohammed.
I think no more further question, Professor.
All right. So
now I think, Professor Rashid, now you can close this.
Okay, just Well, thank you. I have just one question about, if you allow me, Professor.
Sure, absolutely, yes.
Well, how much of this? I mean, I know a lot of insurances and medical litigations, and how much this really contribute to the guideline management? How do they complicate really the procedures of management? Are they really having an input on this aspect?
No, not the insurance and all this cannot really deny. This is an excellent question. They cannot deny any of this because all trauma expenses and work are covered by the state, Michigan, New York, whatever, and the government. So trauma centers here, they get funded to take care of these patients. So it doesn't really come under the influence of any insurance or anything. That's number one. Number two is the car insurance also. A lot of the, probably I think almost all, but I may be mistaken, almost all car insurance companies, because you cannot drive here obviously without a car insurance. So almost all car insurance companies, they take the expenses of hospital costs for any injury. So trauma actually is very well covered. The time when you get problem with insurance companies and all this, and it's mostly in elective stuff where, depends whether you have insurance or not, but most of the trauma work, actually the hospital is very well covered when it comes to the expenses, because they get reimbursed by the government and the state.
Well, thank you, Professor Gamal. Actually, we had a lot of your time, and I think
that's great. I really enjoy being with you guys, and it's an honor for me actually.
Well, it has been a wonderful actually evening, and I think we look forward to see you probably on Wednesday. Thank you, Professor Gamal, and thank all the attendants, and see you probably on Wednesday. Thank you.
Thank you. Take care, guys. Thank you.